So my lecture is basically ketamine clinical uses and thoughts on the mechanisms of ketamine. Okay, our clinic, the Ketamine Clinic of Hawaii, was established in 2013, so it was very, very early. We were the first clinic in the state of Hawaii, and at this time we've done over 3,800 treatment sessions on 723 individuals, averaging about 5.5 sessions per patient. Of course, we don't really give a half a treatment, but that's just the way the numbers work out. The most common one we treat is treatment-resistant depression, which we've treated 442 patients, chronic pain, which is 202 patients, PTSD 49, and something recently we got into, which was addictions. We've treated 16 patients. And then we've treated 14 mixed disorders, which include such things as bipolar, anxiety disorders, and that type of thing. My background is I graduated from the Philadelphia College of Osteopathic Medicine in 1987. I did a general surgery program at NYU, graduated in 1993. And then between EVMS and Eastern Virginia Medical School and NYU, I completed my plastic surgery residency in 1996. And I did a microneural fellowship at the International Institute of Reconstructive Microsurgery. And I'm clinical professor for several osteopathic medical schools presently. I was assistant professor at NYU, general surgery department. And although I'm not on hospital staff at the present, I spent about 20 years on hospital staff at QMC, Capilani, Hilo Hospital. And now I have a private surgical anti-aging and wellness clinic, which we call Infinity Life Center. I've been a pretty well-known teacher in Asia, in China, Korea, Japan since 2002. I actually hold a Chinese medical license and of course, Hawaii medical license. My other ones have expired. And I've been the medical director of the Ketamine Clinic of Hawaii and Stem Cell Treatment Center. How did I get into this ketamine thing? Well, I had a friend with severe depression. She was getting ECTs monthly, and I was looking for alternatives for her. So I started perusing the literature and came across a couple of articles about ketamine. So we tried it with her, and unfortunately it was not a success because I used it like I would an anesthetic as opposed to the way we do it now, which is a very low dose. It frankly scared her and she didn't want to do the treatment anymore. But I kept doing a few more cases. Some psychiatrists in town heard I was doing that. And I started observing a lot of success. And so I started delving deeper and deeper into this area. At that time, there was no ketamine clinic here, and it seemed to be a need. Now, I have a lot of experience with ketamine as an anesthetic. As a plastic surgeon, we use it as an anesthetic all the time. And I probably had 35 years experience with that drug. And also I was trained in critical care from my general surgery days. When I was in Hilo, I was actually a trauma surgeon there for a while. And then my experience as a neuromicrosurgeon, I'll get into what that is with CRPS patients, which is basically peripheral nerve injuries and reanimating paralyzed faces and brachial plexus repairs. Is very, very heavy duty surgery under a microscope. I don't have any experience in mental health, but took referrals from mental health care professionals. Just a little history on ketamine. It was first used as an anesthetic in the 1960s. It was extensively used in the Vietnam War. Due to its safety profile, they gave it to medics to administer to wounded soldiers. However, in the year 2000, it was first reported to have antidepressant properties when it demonstrated that an intravenous IV administration of a small light dose, sub-anesthetic dose.
Dr. Pasquale, can I ask you?
Yes.
Can I ask you a question? Are you advancing
Yes.
your slides? Because we still see the first slide.
Oh Lord, yeah, I am.
Okay.
Maybe we should just send this one.
Yeah, you can get it to me, and then I can advance it, and then I'll catch up to you.
Or
All right, I'll
do you
do that
see
real
do you see the buttons? Oh, because you're advancing them on your computer,
Yeah.
but you have to advance them, and you're sharing on your computer. That's interesting. Do you see the little
Okay.
buttons
I'm
down
sure.
on the left of your screen? The little
No,
advance
just,
and the CC.
Or
I'm
if you
just
click the arrows, the right arrow, maybe.
oh, wait, is that?
No.
I'm thinking the arrows on the bottom left of your screen might do it. What do you think? Well, you could just send it to us.
Recording in progress.
Okay, I'll send it to you. I think you can put it up there. Maybe my screen's too small or something, I don't know.
I think it's a connection between the computer and the Zoom.
Okay,
They're
I'll
not
send that.
talking.
They're not talking to each other.
They're not talking to each other. They need to talk.
All right. Well, I will send this to you right. I will send this to you right away.
Okay,
Yeah,
but
I
keep
don't see
going.
it.
That's very interesting. And I find it really interesting you're from a surgery background where I thought the folks
Right.
doing ketamine would be from a mental health background. So that is really interesting.
Well, it's and I'll get into some of the reasons why of that in just a few minutes. I mean, you got to understand, ketamine is an anesthetic, and a lot of psychiatrists haven't touched a needle since medical school, and it can be tricky, especially when you do it when you're doing it intravenously. And you have it can affect the blood pressure. Breathing is usually not a problem because it's actually a bronchodilator. Even in the low dose, I've seen some irregular heart rates, and you have to have the equipment in your office, which we're a surgical center, to manage these kind of complications and the knowledge to do so. I'm sending this now.
Did you send it to Dr. Witty or to my email?
What is your email?
Okay. Oh.
I sent it to Kelly Withy, so that's Dr. Withy, yeah. You're Summer, right?
Yes. But
I'll send
either
it to
of
you
us can
too.
share it.
I'll send it to you too as well.
Okay.
Yeah, I'm sending it now. Both of you should have got a copy. Anyway, so I mean, it is an anesthetic, and like I said, a lot of psychiatrists don't feel comfortable with administering ketamine. They haven't started IVs. They haven't done that in many years because a lot of psychiatrists are talk therapists, right? So I think that's why I kind of got into it. And the main reason is a lot of psychiatrists sent them to me, knowing that we have the equipment to deal with those patients. So we don't accept patients here unless we do for mental health. We don't accept patients here unless they are, here I see your scribe, unless they're referred by a psychiatrist.
Perfect.
Okay,
Is this the right one?
We'll start here again. I'm sorry for these interruptions.
Don't worry.
As I mentioned, it was first used extensively in Vietnam War, and it was first reported to have antidepressant properties in 2000, when it was demonstrated that intravenous IV administration of a low-dose ketamine resulted in reduction of major depressive disorder symptoms. And they continued to have a reduction for 72 hours afterwards. That was by a couple of doctors, Berman and Capella. Nasal ketamine spray was rushed into approval in 2019 as an antidepressant. You can go next slide. So what is ketamine? It's a dissociative anesthetic, a psychedelic, hallucinogenic, not at the levels that most people get. If you get hallucinations, you would have to stay awake. And if you get the levels where you get hallucinations, you would have to, most people go to sleep instead. It's an NMDA receptor antagonist, and more about that in a minute. It can be used as a general anesthetic. It can be used as an analgesic, an antidepressant. Of course, it's used as a party drug on the street, which I don't know why anybody would use ketamine, get in a K-hole, you don't enjoy it. Most of the drug users I've talked to say they don't enjoy it, they just did it. And of course, the media painted it as a horse tranquilizer, which is just an anesthetic, like any anesthetic. Next slide. So this is, how does it work? This is interesting. The N-methyl D-aspartate, which is NMDA receptor, is a receptor of glutamate, which is the primary excitatory neurotransmitter in the human brain. Now this is important, that's why I kind of bolded it there. It plays a large and integral role in synaptic plasticity, which is a neuronal mechanism believed to be the basis of memory formation. Remember that line. Note that basis of memory formation and synaptic plasticity. Frankly, no one's 100% sure, despite PET scans, extensive research at this point, how this stuff works, but this is sort of my theory and some people agree with me. Next slide. Okay, so I mentioned I was a microneurosurgeon and we repaired a lot of nerve injuries. And a lot of these patients, what would happen is we'd bring them to the operating room, we would expose the nerve under the microscope, and they had like severe pain or malfunction. And we intraoperatively, inside the operating room, we put a needle distal to the injury and proximal to the injury and run electric current. So they would show abnormal conduction. We'd do our magic in surgery, repair the nerve. Before we close them up, we repeat the intraoperative EMG, and it showed normal function. So wow, we cured them, right? Well, 60 to 65% of those patients after the operation didn't get any better. But physiologically, they were working perfectly well. So that is one example of where is the pain if it's not coming from that area. Same thing when you think about a phantom limb pain, an amputee who's complaining of foot pain. There's no foot, so how could the pain be coming from the foot, right? So where is the pain? That's the secret. Next slide. It's centrally based. After time, and I happen to have pain the best, so the cutoff is about 2 years. If they have that pain in their foot that's not there, or they have that pain in their hand from a peripheral nerve injury for 2 years or more, then that pain is moved into the brain, basically. And this is my concept of things and the way I visualize how ketamine works. Chronic condition leads to an error in brain, let's call it homeostasis. That is to say, a permanent rewiring to the new normal. Unfortunately, the new normal is pathological. So recall the slide we just saw about neuroplasticity. So the neurons form actual physical arrangements to remind the brain what this memory is, and it's implanted as a memory. So the same thing would happen with the pain area, it's all in the frontal lobe, or the depression area, where these neurons form these fixations that are abnormal. Well, next slide. So ketamine increases neuroplasticity. In other words, what it does is it allows new connections to form, the old ones to diminish and reconnect. So essentially what you're doing is rewiring the brain. Now, these new connections hopefully won't be pathological. as in depression or as in pain or in addiction we're finding as well. But there's a lesson to be learned from plastic surgery, and this is the overall concept. The concept of homeostasis. The body, like in the brain and the body as well, and most things in biology, like to maintain a steady state. If that's an abnormal state, and it's been there long enough, the brain or the body thinks that's where it should be. That should be the state that it'd be in. Now, let's take, for example, in plastic surgery. The septal deformity is where the nose is crooked. So we go in as plastic surgeons and we do our best to bring the nose back into alignment so it's no longer crooked. It's one of the harder things we do because the memory of that cartilage is so long that the nasal septum wants to move back to where it was before. And I imagine through most of biological systems, that's the way. It's the homeostatic or the steady state. And it would apply with the neurologic aspects as well. So what do we do? With the ketamine patients, we give them treatments, a series, which usually does change them. And then what we have to do is give them a touch-up treatment later. When that touch-up treatment would be, it's totally dependent on the individual. I get asked all the time, well, when do we need a touch-up? And my basic answer to them is, when you tell me you're ready for a touch-up or need a touch-up, because everybody responds differently. Next slide.
So we have a comment that, well, we have a few comments, but Michelle says that they've had patients from the behavioral health clinic who received this treatment at Tripler for resistant depression. That's excellent. And then Dr. Cohn from Maui says the pain in the brain appears permanent, but there is plenty of experimental evidence that discharge, in quotes, causes neuroplastic recovery. Does that sound, is that what you're saying?
I'm not sure what you mean by discharge.
I'm not either. Hey, Dr. Cohn, what do you mean by discharge? Do you mean the medication in the brain causing discharge of neurotransmitters?
Is he thinking like an ECT where there's a convulsion and lots of discharges of the neurons?
Not at all. I'm talking about a listening process where a patient, a client is supported in having their feelings that unmask the original trauma, allow them to get off the emotional charge, and that leads to neuroplastic changes in the brain, eliminating the cause or the remainder of the problem. It's from reevaluation counseling. There's plenty of experiential evidence to support that it works, but there is not a lot of science on it because there's no money in it.
So discussing it, discharging it that way. Interesting.
Yeah, it's what psychiatrists could be doing if they were actually not prescribing medications and listening to their patients and letting them have their feelings and expressing them in ways that they're comfortable.
Obviously, talk therapy works for a lot of conditions. I mean,
it's not
talk therapy. That's what you're talking about, basically.
Check out rc.org.
Right.
Okay, great. And there's also a question about if it's covered on insurance, but we'll get to that at the end. How about that?
Yeah, I have a question answer period at the end. Okay, so basically our protocols, pain patients I take with no referral. I'm qualified. It's 4-hour treatment or more with very low dose. It seems to be what works on most patients. Mental illness patients, they have to have a psychiatric clearance, and that's an hour treatment typically. There are clinical patients have a licensed nurse experienced in the ketamine room with them, continuous monitoring, blood pressure, O2 sat, heart rate, EKG if it indicated, especially in older patients. For research, all patients have an appropriate scale taken. We were trying to write some papers on a lot of this, such as a pain scale, depression scale. It's taken at each visit. They come to see us. Next slide. So we are producing some papers. This is just a paper we're working on now. We're adding more cases to it and resubmit it for publication. It just studies the intravenous ketamine treatment for patients suffering from depression. And we just put together a Montgomery-Ashburg depression scale, check the numbers, and it's very, very encouraging. Next slide. Okay, I have some personal random thoughts from what I've experienced. Some people aren't going to like what I say, but okay, and let's make it back to what the doctor was saying earlier, money in it. They have nasal sprays and lozenges. You can order lozenges from a compound pharmacy. I wrote the FDA when this first started coming out, and I knew the drug companies were going to try to capitalize on as much as possible. And they came out with the nasal spray, ketamine. And I know what their ultimate goal is. It's to put in every family doctor's, nurse practitioner, PA's hands the ability to give their patients nasal spray. So you look, feel depressed, here, try this. And they'll make a ton of money. And same thing to some degree with the lozenges. So I wrote the FDA, said I just oppose this. I think it's going to lead to abuse, just like the fentanyl crisis. The problem with the ketamine, and the studies are starting to bear this out, the nasal spray ketamine, is there's such variable absorption. People have different thicknesses of mucosa and everything else, that it's not getting to the level or as effective at neuroplasticity as the IV therapy is. And so that's just my personal feeling. Maybe I'll get proven wrong, but I don't think so. So who's qualified to provide ketamine therapy? There's some basic requirements, or IV ketamine therapy, I should say. One is I think you need to know how to monitor a patient. You know how to start an IV. You know the side effects of the drugs, and you know how to treat the side effects of the drug. Young people can get into supraventricular tachycardia, and you should need a situation where you have the facility to resuscitate somebody, not just do it in the corner of the office like some people do, at least for the IV stuff. And I think there's potential for abuse for this. We do get ketamine patients in here all the time saying, "Oh, I just want to try the ketamine. I need more. I need more." And we stay away from those patients. Those are just some personal thoughts, my experience of a number of years working with this modality. Next slide. Shows my contact info. I think I have a couple case presentations, maybe. Go to the next slide, if there's a next slide. Essentially the wrong slides, back up. So basically, I had put in 4 case studies, or just experiences we had with patients which exemplify the ketamine experience. We had a fellow here, he was an addiction patient, and I haven't done a lot of addiction patients, but it seems to work very well. He was a 54-year-old businessman, very unusual career. He bought, if any of you know what MiGs are, they're fighter jets for the Russians. He bought about 7 or 8 of these things when Russia was cheap, and he's from Quebec, Canada. He's a pilot, and he makes a lot of money flying with his pilots. They come down to Hawaii to the Marine base, and they fly against the Marine planes over here as the opposition force. So our pilots here get to practice against Russian aircraft. Anyway, he's an alcoholic, bad one. And he was getting ready to lose his pilot's license, which would have destroyed him. So I actually met him. We have a service called Hangover IV. My nurses go out, and he called us about that. And he said, "Oh, this IV makes me feel really well. It's just B12 and banana bag, basically." And my nurses told him, we do this ketamine clinic for addiction, because he was talking to her about that. So he came in and gave it a try. We gave him 5 one-hour treatments, And it completely kicked his habit. And he was exercising every day. He got his blood pressure down. And I've had, of the 16 patients of addictions we've done, and that's ranged from cocaine addiction, multiple drug and alcohol addictions, um, and alcoholism. At least 3/4 of them have been able to kick their addiction, and that's been for over 6 or 7 months.
Oh, do you think it's the craving or the mental habit that they've kicked? Do they tell you, I just don't want it anymore? Or do
Yeah,
they?
that's most of them do say, I lost the craving. The mechanism of that, I'm not sure, but that's very interesting.
Yeah,
Um,
wow.
I want to try it on some patients who smoke cigarettes too. I think that'd be kind of cool. But
It would be
that was
interesting
a
if
big
they,
surprise.
yeah, if they use the substance, do they go down the same rabbit hole that they need more and more and more? But I'm glad they don't use it.
Well, yeah, we haven't had those patients. I mean, I've had a couple patients that were kind of goofy and they were referred and they're mental health patients and they just keep wanting to increase their dose of ketamine. And or I've had them from other ketamine clinics. I guess I had one the other day. She came in from a ketamine clinic in Washington State and she said, "Oh, the nurse practitioner was giving me 400 milligrams over 2 hours." And I don't remember anything. I was out of it. I think if you go to that high dose, I think you don't get the neuroplasticity. I think you're just out of it and the brain just kind of clunks out. So we lowered the dose on her and she's actually doing much better. The other case, okay, so the next case presentation I was going to do was this was a university professor and he had nasopharyngeal cancer. And I'm not sure of the nerves that were affected because it's a very confusing picture. But he was in severe pain for years, for years. And he said the pain every day was like a 10 on a 10. He tried everything, narcotics, nerve blocks, meditation, acupuncture, everything. And he had 5 ketamine treatments in a row for 3 hours each at around 225 milligrams over the, and the pain completely went away. I mean, that guy was a miracle. And that most patients get a pretty good reduction if it's true CRPS or neurogenic pain like that. But he was probably the best case we did. I mean, it was very rewarding. I'm his hero. Then most patients we see are, as I said, showed in the numbers to begin with, are treatment-resistant depression. These are sent in by psychiatrists, psychologists, other mental health care workers. And what we do is our paper is going to show when it's completed, if the numbers continue this way, is we give them the Montgomery-Ashburg depression scale, which is just a 50-point scale. The higher the number, the worse the depression. And then we wait and do it every day, and then we do it about a week afterward to see where they are. On average, our patients have dropped about 15 points on that scale, some of them much more. Doesn't matter the age, young or not. Occasionally, when we get referrals, this is an interesting case. I had I was sent a case by the university, Barry Carlton's group over there, and they were doing a ketamine study on, and Dr. Yu, I think it was, sent them over here because they were restricted on how much ketamine they could give. And I'm in private practice, I can give as much ketamine as I want. But then they were under the restrictions of the study. So he called me and said, "Can you try this patient? I don't think she's getting a high enough dose." So she was a 56-year-old nurse who was retired because of disability. And we tried 3 treatments on her, 1 hour each, with a higher dose. And she was not responding. By the way, she came in with her 93-year-old mother who was taking care of her. Very strange. And every time, the first time I did her case, she started chirping like a bird. It was very strange. And you know, over time, you do this to many patients I do, you kind of get a feel for how they should react to things. She wasn't reacting well. She was making all these animal sounds during the ketamine treatment. So I ended the treatment. So maybe we should do better the next time. Usually we find if they're not responding by 3 treatments, it's not going to work for them. So we did another treatment, same thing. And I was telling her mother, I said, look, I don't know if this is going to work. And she goes, well, just try one more time. So the third day she comes in and she was making more animal signs like a bird or chicken or something. And I said, this is not working for her. So I sent her back to Barry Carlton and I said, you know, maybe try ECT on her. So remember I told you I was inspired by a person that had severe depression, was getting regular ECT. So I talked to her that day and she goes, you know, I said, how'd your ECT go today? Because it totally normalizes her. She goes, it was pretty good, except for there was this weird patient next door was making all these chicken noises. I said, oh, I know who that is. So I called Barry Carlton back up about a week later. I said, a little bird told me you did take her for ECT. And he says, yeah. I said, did it work? He goes, nah, we misdiagnosed her. She was psychotic. So it's a funny little story. It's been a real great experience for me to do this clinic. I mean, the patients have been, for the most part, wonderful. We haven't had any bad experiences. We had a couple of patients, quite a few patients who have not responded, such as the one I just mentioned, and it's usually due to a misdiagnosis. Same thing with pain. If it's it's not CRPS or that type of pain, they're not going to respond well. Well, I'm open up for questions if you have any, and thanks for letting me talk to you.
Yeah, there
Any
are a couple
questions?
about coverage, insurance coverage. So I'm
Yeah.
assuming it's covered for refractory depression.
I
Is
haven't
that,
found an insurance company yet to pay for anything. We've tried,
oh,
we've
shoots.
documented everything, and it's terrible. I mean, even workman's comp said they gave us pre-approval and they're still not paying. So we don't put
How
much
much,
faith in that.
so how much does it cost? Like for a 1-hour
Um,
treatment?
well, it depends on the individual. Our standard rate is, I have found that this treatment protocol works the best. There's many protocols out there. There's about 20 different protocols that are pretty widely accepted. I do 5 days in a row, and the reason why is I've just found that really increases the neuroplasticity, gets it done, and the patients have responded well. Other people do like twice a week for 5 weeks or things like that. I just do the 5, and so our pricing is we sell a package sell. We give a package price based on that treatment protocol of $4,000 for 5 treatment or 6 treatments. So what we tell them is do the 5 treatments, and we feel pretty sure you're going to need a touch-up treatment in the future, so you'll have that available to you. And
Got
you know, there's patients I lower the price a lot just because I feel really bad and they just don't have any money. And that's the kind of doctor I am. I'm kind of
So it's not
sliding
covered.
scale to a degree.
Yeah.
Huh?
So it's not covered for anything, substance use, depression,
No,
nothing.
and believe me, we tried to get a lot of patients covered. You know, it's still in the research mode, and you know, the insurance companies are going to use any excuse they can not to pay. We even tried PTSD at the with TRICARE and all that. Nothing.
Nothing. Even for veterans, huh? Nothing.
Yeah, I thought we had a really good shot with this one fellow, but
No.
with the workman's comp case, we got paid for saline IV therapy at
But not the ketamine.
$67 a bag. I paid $67 a bag.
Oh boy.
Nursing time, equipment time, Yeah, it adds up.
How about, are there any reports that other desirable habits are disrupted as in addition to the addiction when you treat the addicts? You said the addict was
No.
eating healthier and stuff. What do you think of that?
Yeah, I think, well, I think it does put people on a very positive new beginning. I mean, some of it's just, a lot of it's very much psychological. You know, I explained to them, you're going to get rewired. And I think a lot of that really helps with the effect. Oh, I do want to mention, we have tried, there's a fellow starting a ketamine clinic here, and he had one of these patients. He asked my advice. Um, the anxiety patients or these mixed disorders, they're difficult. They do not respond like depression or pain or substance abuse. They're like a mixed anxiety type thing, or bipolar. We have one bipolar patient we've been working with that's actually working very well on her, but for the most part, I try to stay away from them, or at least tell them, you know, I can't say this is going to work. And I remember his first patient was mixed ketamine, anxiety, depression, and the guy flipped out on him during the session. He asked me what he should do. I said, maybe not do the treatment. But I don't know. I think it's the whole psychedelic field with LSD and everything. It's Timothy Leary, I think, was right about a lot of things. For those of you who are old enough to remember who he was. So, I mean, it is still researchy. The exact dosages, I don't know if we'll ever have an exact dose. I mean, you read the literature and so 1.5 milligrams per kilogram, all that stuff. But to me, just because I've been doing it a long time, I'll increase the dose on patients just by watching how they respond. And it's a drip, so you can turn it up or turn it down.
How
There's
about
just a certain mental state I like to see them in.
yeah, how about in youth? Do you know what the current status of the clinical trials are for ketamine in youth?
And what?
Youth, under 18?
Yeah, I have, there isn't a lot of literature on it. I have 3 patients that are, one is suffering from PTSD. She's 15 years old. She was involved in a carjacking. Her dad's a psychiatrist. And we've been working with her. She seems to get really good results. I have another chronic pain patient, which we're getting ready to try. She's 16, I think. I gotta be careful with her. Her dad's a lawyer. But and there was one more patient. I'm trying to think of it. She was young too. I assessed the patient, and you know, there's 14-year-olds and there's 14-year-olds, if you know what I mean.
Yeah.
And these gals they're all girls, by the way. They're very mature. I felt safest with the one whose dad is a psychiatrist. But he said that's worked great for her. So.
Oh, that's high praise then. Do you think that if it's rewiring our synapses involving depression, is it rewiring anything else, you think?
Probably. I don't know. I don't know.
Interesting.
The PET scans do show a lot of activity in the frontal lobes, and but I mean, well, I think I'm convinced the best descriptive and the way to visualize it is rewiring brain, because these people just, you see these changes in them. They're not just, oh, my depression's better. It's their whole attitude. I'll share something with you. One of the reasons I kind of got into this too. Maybe I shouldn't, but I don't care. I'm an old guy. When I was a young kid, you know, I grew up in the hippie generation, right? I was raised in strict Catholic schools. I was kind of browbeaten, introvert. And well, at the time, LSD was a big thing. And I did LSD for about a year and a half, almost every weekend. And it changed me 100%. I went from this introverted, non-creative, very inhibited young man to very creative, very self-confident, became a plastic surgeon. I'm very artsy. I visualize things very well. Who knows? I think it was due to the LSD. I think it rewired me.
Well, Timothy Leary would be proud of you. But that's really interesting.
Drugs. I went in the army. I went in the army after that and haven't touched drugs since. But
yeah, I was going to ask you what you thought of the hallucinogens, the mushroom usage and the LSD usage. You think it's the same type of reaction?
Probably, but the problem with mushrooms is, for one thing, it can make you vomit. I've had patients that have told me they tried the mushrooms. It makes them very nauseated. I don't know, maybe you guys have more experience with mushrooms, but that's what they told me. And the thing is, LSD, of course, is not been studied enough, and we don't have pharmaceutical grade LSD.
Right.
But I think there's room for the psychedelics, if you will, in mental health. And definitely been a boondoggle in chronic pain. I mean, because listen, I when I was a microsurgeon, I treated hundreds of patients, and like I said, the EMG showed perfect result, normal EMG after surgery, but they didn't get any better. And this is the first time it's been so rewarding to see these chronic pain patients get some relief from this drug. So,
oh, sorry, there is actually a question about that. So Claire asked, the neuroplasticity remodeling was shown during the microneurosurgery with the before and after EMGs?
No. This has nothing to do with the ketamine and its effect. What I was saying is, my whole point of the whole thing was, we would see a peripheral nerve and you look under the microscope and you see a dent in it and maybe some scar tissue around it. And you do an EMG and it shows something called an F wave on the EMG, abnormal conduction. We go in with our microscope, we open the nerve up, the neural sheath, remove the scar tissue and fluff up like a sausage that you cut the skin on. Then we repeat the EMG and it showed normal conduction. So physically, you corrected that injury that was supposedly causing the pain. You wake them up after surgery and they still, 65% would still have that pain. So the question is, why? So my point was, it's in the brain now. The brain has become wired to accept that as a new normal. Mm-hmm. And due to homeostatic principles, whatever you want to call them, the brain says, this is my normal. I'm keeping this guy here in pain.
But you don't do EEGs or anything before and after?
No.
Or PET scans or anything? Yeah.
No. I wish we had the funding to.
Yeah, I know.
Just a private guy.
Yeah, so we have a couple other questions. One is, can you describe what the patient experience is like, what you see in the patient? Because you said you'll adjust.
Yeah, I know exactly. I know exactly the question. Okay. So, and I tell them, I prepare them for this, or my nurses do. And like I said, my nurses stay in the room because sometimes we've had to use Versed if they get anxious or something like that. They monitor them closely. Typically, the patient on ketamine, it's a slow drip, so it increases the blood level slowly. As that rises, they'll feel like if we're talking to them or hear noises or they're in a certain environment, maybe looking at something in the room, they'll feel like they're going far, far away from it. And I tell them, look, you'll hear our voices. We're not going anywhere. You're just going to feel like you're leaving. And if you get into trouble, just talk to us. You'll hear our voice and we can, help you from there. So that's the disassociation. Occasionally, I've had a few patients that have, seen hallucinations, very mild little hallucinations. Some patients have relived experiences very heavy, they'll cry. If you get knocked out, I don't think the treatment works. I mean, then you're at the anesthetic level, and it's just the brain's resting. So I don't think much is happening. That's why that one patient who came here and said she was getting 400 milligrams.
Yeah.
They just like, that's strange. It doesn't work. So
Yeah. So maybe they have to be aware of what's going on or something. Very interesting.
they have to be, their brain has to be alert. I mean, I'm sure if we did an EEG with somebody on 500 milligrams of ketamine or something, it's going to show little or no activity. It's a general anesthetic,
Yeah.
right? So that's why you only give low dose.
So there are some people who have don't process the ketamine or anesthetics fast. Do you ever think maybe we need to test if people have that genetic background?
I wish I knew a test.
Okay. True.
Mind Bloom or something, not Mind Bloom, there's tests for, I know that the psychiatrists use some tests for some of the psychiatric drugs to see if they're
Yeah.
going to work for them.
I was hoping it would be for this. So maybe that's a question in the future.
Yeah, somebody
Let's
should
see.
develop that if it isn't done.
Yeah. Ooh, get rich quick scheme. Ooh, I like it. So Dr. Weir in Guam says, is there a future for this treatment in the field of drug addiction? 1 week of therapy at $4,000 should compare favorably with 1+ month of inpatient therapy from a cost standpoint, with hopefully better long-term results. Excellent point there.
That would be great if we can prove that that's the case.
Yeah.
Because I know one of the patients, he went into a home situation, or what do you call it, rehab center, rehab, stay there for a month, and he said it was like being in basic training, and paid like $30,000 at some highfalutin place in California, and didn't work. And then he came to us, and that's one of my addiction patients who worked very well. This guy had cocaine addiction, alcohol addiction, and who knows what else. So hopefully it does prove to be that way. There's just not enough literature yet.
Well, I'm glad you're publishing then. Yeah, it's good you're publishing. Let's see. Assad says, is IV ketamine offered anywhere else on Oahu besides your clinic?
Let's see. I know Dr. Cook, he was doing the IV ketamine for a while. He had a nurse practitioner doing it. And then I think he's just doing IM in his office now. I don't know. And I know there's a bunch of people want to do it.
I've heard that.
I don't know. You said Tripler was doing it?
Yeah, somebody commented that they had it done at Tripler. And then that
I haven't heard that yet.
Okay, so maybe, interesting. So we'll have
might
to
have been part of a study or something. I don't know.
Michelle says she's not certain if Tripler is still offering it. Oh, sorry, our time is up. We were so engrossed, our time is up. But one last question. How is the ketamine induced dissociation, how does it differ from dissociative disorder responses?
Well, since I don't know what disorder, the last thing you said is I can't help you with that.
Fair enough. And Dr. Cohn left us a link to reevaluationcounseling.org, and he says there's at least one person doing it on Maui, but I'm not sure, if he's allowed to share that. So, okay, well, there's a lot of thank yous in the chat. So if you can see the chat, go ahead and take a look. This was this was perfect. This was excellent. Your insights, just your sharing of patient experiences was
Thank you
wonderful.
so much.
Yeah, so thank you so much. And maybe you can come back late in the year and update us on stuff.
Sure. Thank you very much for having me.